On to the next talk, which will be given by Professor Chrit Moonen from the Academic Medical Center in Utrecht, who will talk about this project, which is entitled SOUNDPHARMA.
Okay, thank you, Twan, and thank you for Beat for inviting me here to present this this work on the project SOUNDPHARMA. It's an advanced grant on image-guided local drug delivery from nanocarriers using focused ultrasound. And one of the tasks is also to help you, I think, give you some advice, and if you want to apply for such a grant. And I start actually with that. So the ERC grants, how you might want to do it. So there is no really magic bullet, but some advice. I think there's certainly one is that a major thing of these grants is thinking out of the box, revolution, not really evolution. So that's one important thing. Starting, of course, from your strengths, but broaden it to really a big picture, a big theme. Those things. The strong CV is, of course, a big asset, but it's not the most important one. Highlight in your CV, highlight the innovative steps that you have taken. Seek the help from your university. University often provides help, and also previous grantees. Also here, the people who got some grants. So I would say go for it if you have a good idea, but work it out very well. So and part of it is just to highlight a little bit on this. Personally, I'm not from the pharmaceutical side. I'm an imaging person, and part of this is to these steps into the CV in that highlight the innovation. They are helpful, and I think that this is just for my own personal things, of course not important, but I started from protein structure by high resolution NMR to magnetic resonance imaging, then moved to physiological and functional MRI, to MR-guided therapies, then to MR-guided focused ultrasound for tissue ablation, then to focused ultrasound for local drug delivery, and then to ultrasound-triggered local drug delivery, the project called SOUNDPHARMA. In 2009, this is the first time that I applied for the grant. I didn't get it. I was evaluated as B, so not funded, but good enough to reapply, with very valuable feedback. And that feedback was exactly what I highlighted, that I actually, in my first attempt, I gave too many details, not enough attention to the big picture, to really the innovative steps. And in 2010, I applied and I took care of these critical points and I got it. So these are some lessons, I think, to take care of, and then, so when you want to apply. So from that, I really want to get to the scientific part and to the image-guided drug delivery. Overall, this is a theme that also in the molecular imaging, in the societies, European Society of Molecular Imaging, the World Molecular Imaging Conference, that they also is paid quite a bit of attention to this theme. Of course, overall, any image-guided action with the purpose of increasing the local drug concentration while decreasing the systemic toxicity effects belong to this field. In this particular case, this is really my grant. This project, SOUNDPHARMA, had to do with lowering the barrier from drugs from the moment that they enter the body until they reach the target, using external energy, and in this case, of course, ultrasound. What is so special about ultrasound? Ultrasound is, of course, a mechanical wave that you can from outside send inside the body, and it leads inside, because it's a mechanical wave, it leads to shear forces. That is just basically non-uniform displacement resulting from the strain differences. And they have a lot of effects, bioeffects, that are useful for drug delivery. Permeability enhancement in endothelial and other cells, also referred to as sonoperation. Widened intercellular spaces, helping diffusion. Increased extravasation and diffusion through the interstitium. And of course the absorption of ultrasound energy, leading to temperature increase that can in itself have many effects on both extravasation, on crossing different barriers. So these are referred to here to a few reviews. Actually, most of it is a very interesting series of reviews. In Advanced Drug Delivery Review, that's the issue that is coming out actually right now. The preferred technology that we work in the clinic, and this is of course very much an attempt to get these ideas into the clinic, is an MR-guided focused ultrasound. This is a conventional MRI. The only modification is that there is an ultrasound transducer incorporated in the bed. You see that here. This is actually leading to, this is depicted, all the sound waves that is coming from each of these elements. They are coming here together in the focal point. And the focal point provides you then the targeting. So this is not your ultrasound imaging that you interrogate a very wide region. This is really focusing all the waves in one spot. And this works very similarly than an optical lens, that the focusing of optics into a focal point. Now, what is the dimensions here of this focal point? It has to do with the wavelength. The wavelength that we are using here is about 1 millimeter, and the dimension here is of the order of 1 millimeter. Now, the MRI is then, of course, you know it. The MRI is used for providing a lot of anatomical detail and providing the target. Where do I want to focus? Once you have that, actually, it's an interesting feature that MRI is the only method that actually can reliably give you temperature maps of temperature changes during your intervention. So first you use this for targeting, and then you use it for actually adapting the energy, because since you can measure the temperature inside the tissue and actually in the focal point, you can actually adapt the total energy and really reach a hyperthermia or even a very high temperature if you want, in a controlled way, this MR-guided HIFU. So with that technology, the applications of focused ultrasound in drug delivery, there can be on many parts. Extravasation already mentioned, blood-brain barrier, it has been a lot dealt with at this conference already, today even, so I will not talk about this. I will talk about membrane permeabilization, trigger drug release from nanocarriers later on. So this is here, as you see here, individual cells measured with a fibered optics, and measuring each individual cell. You can see these cells highlighting during after an ultrasound treatment in the presence of microbubbles. So these microbubbles, they push against the cells, and as a result they take up here a compound. We use it as a drug, model drug, Cytox green, or one of other compounds that actually fluoresce, that have no fluorescence when they are not together with the nucleic acids, but their fluorescence increases more than 100-fold when they're combined, when they intercalate with nucleic acids. And that's what you see here. These compounds, they normally do not enter. They do not go over the cell membrane. After this sonoperation treatment, you can see each of these cells, each of this is a cell. They can light up because of the model drug actually gets in and combines with the nucleic acid. So for each individual cell, you have the pharmacokinetics, you have the take-up and rate, and you can analyze each individual cell. And you can do this now. Look at this, for example, in temporal window. If you do this sonoperation step, and it's shown that it's also these techniques work in vivo, so these bubbles, they go into the bloodstream. You expose it to ultrasound, and you get sonoperation of, in particular, of course, the endothelial cell layer. This is an opticell with single layers, the SonoView bubbles. Some of the ultrasound exposure details that I've given you here. If you look first at the bottom, this was earlier work from Anna Udina. Here you see at this that even this is when you give this model drug, or 6 hours or even 12 hours after this sonoperation step, you can still see that the cells take up this model compound. So this gives rise to a so-called temporal window. And that, of course, has implications how you would like to do this in the clinic. That means that you can separate in time the sonoperation step and the giving the drug. This was here in a number of different cells in a recent publication or submitted publication, where it's also confirmed that this actually temporal window exists, a bit less long, and here these were glioma cells, these were other cells. You can see here endothelial cells, breast cancer cell line, and other cell lines. It's also, this temporal window is over the order of hours. It's a very interesting idea what this really means and what with respect to mechanisms, but I will not go into detail. I don't have the time for that. Looking at what mechanism, a bit more detailed in the mechanisms are, if you do the same procedure, but then you give different endocytosis pathway inhibitors, because there is the idea: are you really shooting holes in the membrane, or is this somehow related to endocytosis? And if it is endocytosis, is it clathrin or is it caveolate dependent? So you can use different compounds like chlorpromazine that is acting more on the clathrin, and the genistein that using on the caveolate. You use different methods to measure this with fluorescence, either the cholera toxin or the human transferrin. You can see some of the details here. We are using this confocal fluorescence microscopy and using iodine, propydium iodide, to look for if the membrane is still intact. And you can see a summary of the results, that actually in different concentration of genistein here, there's hardly any effect. There's a small effect that is still statistically significant. So these are taken together of hundreds of cells, but here in this case you can see a very clear effect of the chlorpromazine until this concentration, and here the chlorpromazine itself becomes toxic. So this clear effect is showing here that this is really clathrin-dependent pathway of endocytosis. So this is imaging techniques that you can use to study this. This, of course, this technique, since these microbubbles are clinically approved, this step can easily be done then in the clinic. Trigger drug release from nanocarriers. You've heard already about it. This is temperature-sensitive liposomes for local drug delivery, using surface-permeable drugs, in this case doxorubicin. Of course, the ideas, the temperature-sensitive liposomes have been around for more than 30 years, coming from mostly from Duke University, and some recent release that this has given a new life with the advent of MR-guided focused ultrasound for local hypothermia. The idea how this works, and also I'm referring to work from Matt Dreyer and colleagues at NIH, so looking at doxorubicin, and this is especially this row here is very interesting, looking at free doxorubicin here, or low temperature or sensitive liposomes, or that you can see here that the effects of doxorubicin, it's mostly on the outside of the tumor or very close to the vessels. But if you have low temperature sensitive liposomes plus hyperthermia with MR HIFU, then looking at this, you have a much better microdistribution through the tumor. Part of it is still not where you don't see the doxorubicin. Most of that is because those are already these are areas that are not well perfused. The way that we plan to bring this to the clinic is with this with breast cancer. With breast cancer therapy. This is a platform of the MR HIFU, the HIFU platform that is combined then with the MR instrument. This is specifically designed for breast cancer, both for ablation as well as hyperthermia. You can see here the cup where the breast is going into, and you see here, in this case here, and with a better view here, you see all the ultrasound transducer that are around the cup and that are irradiating from sonicating from outside in. So the way that we are going to do this, of course, you are most familiar with this. This is the Thermobox working with Celsion, with the temperature-sensitive liposome with a critical temperature of about 40.5 or 41 degree. This you can see this as comparison with Doxil, that this is here. This is a very fast release when you reach this critical temperature. If you look at the preclinical work showing that indeed this heated tumor, you get a more than 10-fold increase in doxorubicin concentration, whereas most in the other tissue it's pretty much similar than if you would give normal doxorubicin. And that's a very important thing, because some people say it's this because this Thermobox is leaking at 37 degrees, and that would be not a very good characteristic of the liposome. We think actually more and more that this is a necessary thing. At least that is our discussions with our oncologists, because if for those people in breast cancer, in advanced breast cancer, where the probability of metastasis is already very high, you have to have a systemic effect of the doxorubicin as well. So you have to both treat the primary tumor as well as the metastasis. So with that, the summary is that, of course, more from an imaging perspective, but as ultrasound leads to bioeffects that are useful for local drug therapy by increased membrane permeability, blood-brain barrier permeability, extravasation, intratissue diffusion, and local drug release from carriers using either cavitation, temperature, or combinations. Added value of imaging, of course, MRI, temperature mapping, target definition, HIFU control, pharmacodistribution, co-released MR contrast agent. I've not shown that here, but that's especially important for blood-brain barrier extravasation, physiological readouts, imaging biomarkers, and the molecular imaging, the optical, the very high sensitivity, the bridge between macroscopic in vivo and microscopic histological view, and the smart contrast agent specific readout in the delivery process, internalization or enzymatic processes. And with that, I want to acknowledge especially the team from where I am now at the UMC Utrecht and the Pharmaceutical Sciences in Utrecht, where we have a very strong collaboration with Gert Storm and colleagues. And I also want to acknowledge the partners of the European project, of the FP7 project, Sonodrugs, that actually led to a lot of these ideas, and especially, of course, the ERC project, SOUNDPHARMA, and thank you for your attention.
Thank you very much, Chrit. Questions from the audience? Time for 2 or 3, so maybe I'll start. What is the current clinical status now for the Thermobox approach? I know there was a phase 3 trial which is completed with mixed results. Do you know what's going on next?
Yes, the clinical trial, the HEAT trial, was on the combination of Thermobox and RF, radiofrequency ablation, for HECs. And that failed. They did not reach significance, and so that was of course a big bummer for the company. They are reanalyzing the data, and there seemed to be some correlation that where the RF ablation took much longer, where the procedure took longer, that then they had much better results, and that of course corresponds with that. For these things also you need the perfusion to bring the drug, to bring the nanoparticle in. So I think that. Of course, the RF ablation is very different from HIFU in the sense that you reach very high temperatures, so near boiling, where the primary needle is, and then you have, of course, over time you get very shallow gradients. Also, what you do exactly there with the perfusion, it's not very well known what exactly is going on. So I think it's quite different. I think with the HIFU procedure, I think chances are better, I think, to have a better controlled hyperthermia. But that's the situation. I think that Celsion is the company. It's certainly a big bummer, but they're not dead. We are working very closely with them on this.
Are they going to redo liver cancer, or are they going for a different tumor?
I think they are certainly reanalyzing. They are also expanding. They just filed for another clinical trial on this, so expanding on the last and especially paying more detail to the duration of that heating.
Okay, thank you. More questions? Yes, please.
In the beginning you were talking about this micro explosions, let's say, induced by the microbubbles, and I know that this is a common vehicle for transport through the blood-brain barrier, but opening the blood-brain barrier was also in the past not a good idea. Is it different now when you have, let's say, this micro explosions? Because at the end you have an opening, and this means that also bacteria or other factors can enter.
You're absolutely right, and it was actually discussed this morning by our chair, Tom. Yes, the moment that you open the blood-brain barrier, you have toxicity. So that's why it's also very important to look at the temporal window. How long will it take? And of course, because these toxicity will probably correlate with that duration. And MRI allows you to look at extravasation without actually, you can do this procedure without doing the drug actually, but looking at the extravasation of MR contrast agent. And there are actually really good studies that have looked at this closure of the temporal window, and it's of the order of of hours to a day, depending on how big the drug is. That is work by Benoît Lara and others in Paris. But in principle, you're right. You can expect toxicity because of that breakage of extravasation of other compounds. Yeah.
Short last question. Yes.
Thank you for your presentation. About Thermobox, I have a question. I see that you have 8% of doxorubicin in the bloodstream. Do you think that it's really enough for eradicate the metastases? And do you have an idea about the concentration of doxorubicin into the cell and into the bloodstream?
Yes, I mean, with respect to the metastasis, that you have to, that's also one of the reasons why we got this, why we are, our first trial will be on breast cancer, because in the breast cancer protocol for stage 3-4, where the probability of metastasis is high, doxorubicin is part of the cocktail that they are receiving. Now you replace doxorubicin by Thermobox. Now you have to make sure that because of the leakage effect, that the systemic effect is the same as they would reach also with normal with doxorubicin infusion, and that's part of the task that we are looking at now also in preclinical studies to make sure that that's indeed the case. As long as you have that, then I think that the primary, I think we are less, because I think the work that I've showed you from NIH, from Toronto, we confirmed that ourselves. We reached those 10 level higher concentration in the primary, there where we heat. So that we are pretty sure of, but the systemic levels are very important too.
Okay, in the interest of time, we have to move on. Thanks again, Chrit.